So the focus of our talk today is on free text that occurs in medical records. And there's been certainly a lot of interest and attention paid to the fact that while we tend to work with structured information in administrative data and other forms of electronic health data, there's a lot of valuable information that could be mined from free text fields. So things like progress notes that occur in electronic medical records, which have documentation around the health conditions that individuals have, their contacts with a variety of healthcare providers, and also the social context in which individuals live may be found in these kinds of notes. Results from laboratory tests may contain additional documentation about individuals. There is the potential for patient identifying information or even healthcare provider identifying information to be found in these free text fields. And privacy legislation that each of us encounters in our respective provinces and territories requires that this information be de-identified before the data can be made available for research purposes. So if we are to expand the holdings that exist in data repositories across Canada, then we need to be able to deal with free text information that's available, provide assurances to data custodians that this information can be removed from health records. And so hence HDRN Canada was interested in supporting a project that would enable us to explore methodologies and also processes that we could use in order to develop a robust and accurate system for identifying and also masking identifiable information in free text fields in electronic health data. And with that, we put together a project proposal that came from the Algorithms and Harmonized Data Working Group around what we wanted to achieve. And there is as much in this project around processes as there are with many HDRN Canada projects as there is about the outcomes. So part of this is about being able to work through the process of identifying the kinds of personal identifiable information that is available in free text fields. And this comes through the annotation process. In other words, being able to identify and label what is in the electronic health records that we may encounter in repositories. So that's part of it. And we'll talk about that process that we're using, which is really where we are right now in terms of annotation. And then the other is to look at the models that we can use, focusing on artificial intelligence as a tool to assist us in the de-identification process, and the ability to roll that out across multiple sites is part of the work that we're doing and seeing how that can work. And also there's a novelty there in that we're working with a federated learning system. And that is a goal with HDRN Canada, is to advance our understanding of how to do federated learning across the provinces and territories. And then the third objective is about creating resources. So what can be used by other sites? What are the learnings that come from this that might be extended to sites outside of HDRN Canada, so other users of free text information, that we can create these resources and make them publicly available is the last piece of the project. So the sites that we'll be talking to today, we are working at the Manitoba Centre for Health Policy, and also we have expertise from the George and Fahey Centre for Healthcare Innovation in Manitoba. And I'm very pleased with the range of expertise that we have from Saeed, from Abhishek, from Chad and Georgina. In Ontario, we have as well a team there, and also that's and Mahmoud has led that. Ganga is taking over in that respect with Mahmoud's departure in a new role. And in Alberta at Alberta Health Services, we have James who's leading, and we also have other team members who are lending their expertise. But there are really a lot of behind the scenes people who are contributing to this project. When we think about the work that needs to be done, understanding the data that we're working with has been a component of the project. And so we have experts in the kinds of data that we're working with who can provide insights about the challenges. So what kinds of personal identifying information do we need to be able to mask? And what is the process that we should use to extract a set of information for annotation, in other words, to label and see how well a masking tool can perform. We have liaised with IT support and also with those who are involved in cybersecurity as we're looking at new analytic tools that need to be installed in secure environments. And also with an AI-based tool, there's potentially a significant amount of computational resources that are needed. We've had consultations with individuals who are involved in the privacy realm and also from the legal aspect, in that we are using software that may require licensing agreements in each of the sites, especially when we're looking at the federated learning approach. Those who have clinical expertise and also data science expertise are important to have input to the projects. And as well, just managing what's going on across multiple sites. So ensuring that we have the right people in place to help with the project management and also with hiring. So one of the keys for us has been the ability to hire data abstractors and individuals who have data science expertise. They're essential to the project. We need high quality annotated data in order to be able to train the de-identification models that we're working with. And also individuals who can bring expertise in rolling out the tools that we'll be using, and then being able to build the resources that we need following testing of de-identification tools, ensuring that it makes sense, that it's potentially usable and generalizable across multiple sites. So this truly is a team effort. With that, each of us is going to talk a little bit about what's going on at our respective sites. So I'm going to start with providing a bit of overview of the data and also the methodology that we're working with in Manitoba. And as you listen to the presentation, you'll hear, of course, some commonalities in terms of challenges that we're dealing with, but also differences. We know that with many HDRN Canada projects, there's heterogeneity in the processes, the data, and the people that we're working with across sites. This can be complementary, but also can present some challenges in the work that we do. And recognizing the unique needs of each of the sites where we're piloting this de-identification project is an important part of the overall progress and process of the project. So in Manitoba, we're working with free text information that comes from primary care electronic medical records. This is from the MAPCRN database that is part of the Canadian Primary Care Sentinel Surveillance Network. And so in this data, we have encounter notes, which really are narratives that document things like patient diagnoses, the treatments that they may receive, and other personal information. Now, in order for us to be able to access the electronic medical records from the MAPCRN database to proceed with this project, we actually had to go through a pre-de-identification process, or in other words, a pseudonymization process to ensure privacy. And that was simply a requirement of the data custodians and the ability to work on the MASK project. So in our case, we're actually working with data that have already been scrubbed of personal identifying information and replaced with non-identifiable data. But that's been done with in a very deliberate process to ensure that we have data that looks as close as possible to real data. And Saeed Al-Azazi has actually spent some time looking at the literature on how this might affect the results that we have, because ultimately, in the end, if we see differences in performance of our de-identification tool across sites, we need to be able to know what factors might contribute to that. And we're using data over a significant period of time. And that's something that you'll notice may be different from what exists at other sites. So we're going all the way back to 2011. So this pseudo-anonymization process is really a multi-step process where the real personal identifiers are replaced with realistic synthetic ones. And before we do any annotation, that is labeling of the data, or any of the model training that we're going to do with our masking tool. So identifying where there is personal identifiable information within the electronic medical records, and then doing a placeholder replacement, ensuring that there is consistency in the process is a part of that. Looking at ensuring that there's really believable data that are being included in the electronic medical records. And then looking at how we're going to ensure that the records contain the specific kinds of entities that we want for precision in our annotation process is a component of this. And where we are at right now is really focusing on how we will select records. And there's been a sampling approach that's been identified to look at the different kinds of personal identifying information that are available in our electronic medical records, ensuring that we have sufficient numbers of particular types of entities. So that could be names, or it could be addresses, it could be phone numbers, or other kinds of potentially identifiable information, and using a variety of tools to identify these, including AI models. Then the other piece of it is ensuring that we have control notes, those that don't have any kind of personal identifying information. So we want to be able to detect with our masking tool these different kinds of specified entities, but also ones that don't have any of this information, so that we can assess the false positive detection accuracy. And then within the team, there's been a lot of discussion about eponyms. So how we deal with disease names that could also be mistaken for individual names, for example, and ensuring that we have sufficient number of these notes that have medical eponyms in them and are included in the selection process. All right, so we've built certain sampling targets, and we've worked with experts at the Manitoba Centre for Health Policy to kind of decide on the total number of records that we need. We've kind of been working with a starting point of 5,000 records that will be used for annotation. We have hired a data annotator who has a background in medicine, as well as also in qualitative research, that will be very beneficial in terms of this process. And then we just look at ways that we can align with what's going on in other sites, understanding different approaches that might be used for the selection of records and the annotation. And our process mirrors what Ontario had originally proposed, and we're trying to prioritize the electronic medical records that actually have multiple pieces of personal identifying information in them. And this should reduce the overall total number of records that we need and streamline the annotation process. And then finally, thinking about how we can assess the quality of the data that we have to ensure that there's good coverage across different kinds of identifiable entities in the data, so that we can have accurate results when it comes to testing our AI tool for text de-identification. All right, with that, I'm going to turn it over to Mahmoud, who's going to describe what's been happening in Ontario with this project.
Thank you, Lisa. It's so good to speak to former colleagues and collaborators. Thanks for having me, despite my role change. I'm glad that I'm speaking on behalf of ICS for the purpose of this presentation. Although, whenever I say we or we did this or we will do this, I mean ICS will do it, and my affiliation is different right now with Canadian Centre of Recovery Excellence, or CORE. As you all know, ICS is a non-for-profit research institute funded mainly by the government of Ontario, located in Ontario and connected with 6 different sites. And ICS holds multiple designation under multiple acts in Ontario. For example, prescribed entity under Ontario's PHEPA and Coroner Acts, and also Extra Ministerial Data Integration Unit, or EMDIU, under FIPA. And that means ICS has and will have access to more data in a fully identifiable format, which all needs to be linkable and also protected from the privacy perspective. And that's why this project is very important for ICS. And as you see, ICS holds over 110 linkable Ontario population level health and non-health data, which includes a lot of data points. Next slide, please. So free text medical narratives, as we all heard from Lisa, are very important information, but always very tricky to deal with. And I'm showing you some real example, but redacted information, of course, from some of ICS data. For example, on the left, you see COVID-19 test result, which in Ontario is fully text-based. This example doesn't have any identifiable information, but on the right, this is also from the same database, Ontario Laboratory Information System, OLIS, but on the C. difficile test results. And as you see, not only the result is there, but also it has a phone number and also the technician names that performed the test. So these are things that we are aiming to protect from the privacy perspective through this project. Next slide, please. Another example, again, from real ICS data. So on the left, medical imaging interpretation. This also comes from a real scenario. It was saying image acquired under the name Jane Doe incorrectly due to incorrect requisition. So although the field was specific to hold test result, but technicians use that field for also adding other information that could become very sensitive information. On the right, this is another example from echocardiogram interpretation. And we noticed that in the different data context, you have different challenges. For example, in the cardiovascular data, there are so many names, like things such as devices or artificial valve or methodology that are named after individuals. Here you can see Edward as an Edward valve, or Duke, treadmill score, and Jude, mechanical valve. These are all very tricky because in one text, that could be a name of the patient, in one text, not. And you need to be carefully masked or not masked by the context. Next slide, please. And my last example is from electronic medical record from primary care, or what ICS calls EMRPC. This is again a real one from a progress note. 45-year female, feeling well, sleeping better, headaches have passed. Now, new job for 1-year contract. I redacted that part. A director of important affair in the center for very important stuff, and those were real names. And if you Google that name, there's only one person associated with that position in that center. So it's very easy to identify the patient, but that's exactly another challenge for the identification. Next slide, please. So a little bit of background. So how ICS will be doing the sampling for exactly what Lisa discussed and shared with us from Manitoba perspective. We are going to use the older generation of mask, which was developed back in 2017 at ICS. So that generation of this tool was not AI-based. That was rule and dictionary-based tool. And we used the hash objects to store large dictionaries into the memory in the SAS environment. It also leveraged Perl regular expression functions in SAS to identify the sensitive information. For the dictionary, for that version of the tool, we used all unique names that have been ever appeared in Ontario Health insurance card. And we found 1.4 million different names in Ontario for the past 30 plus years. And we also found the overlap of those names with regular English words. Basically, we use an Oxford Dictionary database, open source database from Oxford Dictionary, and we merged it with our names in Ontario, and we found actually there are more than 10,000 names that you can imagine their name or their regular verb or occupation or many similar situations. So we also included context-specific dictionaries such as eponymous disease and virus names named after individual, device name after individual. So this all together used as a tool to currently identify text at ICS, which I'll tell you the issues and limitation. That's why we wanted to have a more new generation of these tools. But you can see on the right, a screenshot of the code is basically a SAS script, but thousands of lines of codes. The main person who was behind this was Ganga Kalapa from ICS, who developed these tools, who is also leading this from ICS perspective, this project. Next slide, please. So in order to enhance MASK, because of the issue that we encounter, which was undermasking or overmasking, the same two examples that you can see, the rule-based and dictionary-based tool was not able to differentiate between whether Edwards is a valve name or Edwards is a patient name. So either you had to tell the tool that mask Edward everywhere, or do not mask Edward anywhere. So that's a challenge. So and that's actually, it could be risky if you not mask it, or it could be actually you can lose the value of the data if you mask it everywhere. So that was the limitation that actually motivated us to collaborate with other entities. And back in 2021, after the collaboration completed with between ICS, University of Manchester, and a company in Toronto, EventSet Incorporation, which all helped to package this mask application, which now we are testing it and we are deploying it in 3 different provinces. Next slide, please. So for the data sampling at ICS for the purpose of annotation and model training, as I mentioned, we use that older generation of the tool, and we make sure that the sample includes sufficient records from all type of identifiable information, such as different type of names, addresses, phone numbers, health insurance numbers, and other similar IDs and job titles. Under the source of the data assets that we identified at ICS that are most suitable and critical for ICS to be masked are OLIS, Ontario Laboratory Information System, cardiovascular data, specifically from echocardiogram interpretation that we had most of our challenges with that type of data. Of course, electronic medical record from primary care, and also another data that we also identified as a very challenging one was the pediatric oncology data, or what's called in Ontario POGONIS. So, of course, all subject to the resources and time, but these are our best candidates for the purpose of this project. Next slide, please. All right, thanks. I'll pass it to James.
Great, thanks very much, Mahmoud. All right, James, the floor is yours.
All right, thank you. Yeah, I'd like to just, before I go into a bit of the Alberta considerations and the data, I just want to reemphasize what Lisa had mentioned about how many people are really involved in this work. So even within Alberta, I'm relying a lot on colleagues and data managers, data scientists, and so yeah, I'll provide more of a high-level overview of what we're doing, the data we have, and some other considerations in respect to how things might differ, but trying to standardize to Manitoba and Ontario as well. So next slide, please. Mm-hmm. So first of all, we have a fairly newly implemented EMR system across Alberta called Connect Care, and it is through Epic, which is a healthcare software company that was actually founded in the US, in Wisconsin. And this is a system that's now, just as of November of last year, is being used across all acute care sites in Alberta. So again, you can already see some of the differences with our data. We're looking at acute care data and don't have primary care data, so there'll be some nuances there. But this is really the source of information that we're utilizing for the MASK project. Next slide, please. So to provide just a snapshot of what the process of this data looks like. So healthcare providers on the front end are using this environment called hyperspace. So that's where they're actually entering information about the healthcare encounters, about their patients. There's even some ability for some reporting and breakdown of looking at their own patients under their care. But what really comes back through on the back end for the data that we work with, it starts off in this Chronicles database pretty much in real time. And so we don't actually use this data. It's pretty much as it comes in directly from the front end. And so it's shifted also into a database called Clarity, which is a relational database. And then data can further go into Caboodle, which is more so used for a lot of direct reporting and analysis. And the Caboodle database is also what can be linked to non-Epic data. Next slide, please. So we actually are going to be using the Clarity database, which is, again, sort of that middle component, but it does have more structure to it than that Chronicles database, but it is quite spread out. So there's over 15,000 unique tables alone in Clarity. So there's a lot of linkage and joining of encounter information to make sure we're linking properly, capturing all the information that we need for the data for this project. And so there is a lot of work ongoing to make sure we're capturing what we need and essentially including the correct information and excluding anything that we don't want for the actual MASK algorithm. Mm-hmm. Next slide, please. So this is another consideration when we think about the encounters that can come in through the Clarity data. So when we think to more of the typical administrative healthcare database type studies where you're looking at things like the Discharge Abstract Database or DAD or the National Ambulatory Care Reporting System or NACRS, we can think about finding those encounters there or even just taking from one of those data sources and thinking about what other information now can we capture through this free text information. So there's various different types of information in these encounters in Connect Care, from diagnoses, lab, medications, and flow sheet, but really the clinical notes is where we're going to get more of that true free text narrative type information that would be really important to apply this algorithm on to see how it works against the private and identifiable information that would be present there. So there's almost 100 different types of this clinical note type data. So some of the most common ones would be the discharge summaries, but there's also some things like patient instructions or operating room information, those kinds of things. But really what we're going to be looking at is the discharge summaries at this stage for the project. Next slide, please. Mm-hmm. And really this is because, well, for a few reasons. It's a very important source of health data, these discharge summaries. It's likely to contain the type of personal identifiers that we're interested in trying to mask. And, from a practical perspective, it's something that would likely be used for future long-term research in acute care or quality improvement in acute care. So it makes sense to really start with this place at this place. And as I said, it's been a continued rollout of Connect Care across the province over time, but now this is really something where we have direct access to information across over 100 acute care sites in the province. Thinking a bit more about some differences from data in Manitoba or Ontario, the discharge summaries are not likely, from what we've seen, to contain information like social insurance numbers or even emails, for example. In a sense, the discharge summaries are not, they're structured in a way that wouldn't necessarily prompt a provider to include that information. There's other data, there's other tables and other sources of data in Connect Care that might contain that information. So just some of the differences within the actual data relative to what we might see in the other sites. And some of the other considerations is because this is a free text narrative type data source, we've seen that there's some cases where you might have the same discharge summary in multiple rows of data just because that specific cell has a character limit, so it's gone on to include a second row or third row of data, but it's for the same discharge summary. So there's some additional work we need to do to make sure we're capturing that entire free text document for annotation. Next slide, please. And just a bit about the actual data environment, because there's been a shift within Alberta Health Services as well. We actually have switched to a cloud environment for data, so using Snowflake. And so one of the advantages of this is that querying data is a lot faster than the previous infrastructure. So, queries that would have taken several hours are now taking seconds. And that's really an advantage because we are dealing with potentially huge amounts of data when we're in the pre-processing stage of trying to identify the initial records that we want to work with. But there's also the difference now in terms of the programming language or software that's available within this environment. So we've historically used SAS for a lot of querying data and data extraction, but now shifting to Python and SQL. So again, there could be some differences in the pre-processing stage. And that's something, again, we've been communicating across sites to figure out the most harmonized approach possible. But once that data is actually ready to be annotated, we've got the capacity to host that information on the secure computing data storage environment, which is embedded within the University of Calgary. And there's agreements with Alberta Health Services data that it can contain level 4 data like this, so it can store potentially highly identifiable information. But it is an environment where we can have the BRAT software for annotation up and running. And so that's sort of what the infrastructure looks like within Alberta. Next slide, please. So I've touched on some of these considerations already, but just to summarize, again, we're working with data that's specific to an acute care context. So there's going to be likely going to be some differences in our results compared to the other sites, and we'll have further discussions as to what that might come from. The types of healthcare encounters that people are experiencing in these settings is going to be very different from primary care, and the types of healthcare providers that are putting this information into the system will have different practices as well. And beyond that, this is still a fairly new system. So it's, again, this timeline of change management and onboarding healthcare providers and staff, as well as the analysts and those working on the back end with the data. It is quite a bit of a learning curve, so there's some of those considerations as well. And as I mentioned, there's some potential variation in the software or the programming that's used to process and annotate the data. Next slide, please. And I won't go, this slide is not important in terms of the fine detail. It's probably quite small to see, but this is, again, just highlighting that the implementation of this Connect Care system has been really a 5-year process across 9 different waves. So it initially started in November of 2019, and as I mentioned, just finished in November of 2024. So one of our thoughts is, because of that varied implementation, is to try and restrict to sites that have been using this system for at least 1 year, just so we can kind of address some of the issues that might come up in change management or the added variability as users got used to the system and the practices around data entry became more standardized. And with that, I think that will finish up the Alberta component. So I'll pass it back to Lisa.
Great. Thank you so much, James, for that overview. Very comprehensive. All right, I have a few final comments on the methods and then the importance of the project as well. This slide provides a nice overview of one of the processes that we're working through with this text de-identification project. First of all, the tools that we're using are highlighted in the left-hand side. So we have a text annotation tool that annotators in each of the sites are learning or will be learning, that enables us to label the different kinds of potentially identifiable information that is available in free text fields, such as names or phone numbers or email addresses. And then the tool that we'll use for the actual building a model that will de-identify the text is this masking tool that Mahmoud has described, that is a successor to an early tool. This one is an AI-based tool that has the ability to really look at the context of the information around it to determine what needs to be masked. And I'll talk about that a bit more in the next slide. So our goal is that at each of the sites that we will train this AI-based model using our own data and understanding that there is heterogeneity in the types of data that we're working with and even the types of identifiers that may exist. So we will train our own models on our local line level data, but we'll work together in terms of the approaches that we might use to fine tune and adjust the models in a way that we hope is harmonized across the sites. And then comes the federated learning, where we take the individual results from the model and use those to build a common model that we hope could be rolled out across, first of all, the 3 sites to say, well, how generalizable is it to be able to accurately identify and then deal with personal identifying information at those sites. And so the federated learning component gives a standardized process that allows sites to benefit from the collective learning across what is very heterogeneous data. But the final trained models would allow us to work not only across the 3 sites, but also across other sites. And it could be updated as well over time or with the addition of new sites while still maintaining the security of line level data at each of the sites. The masking tool that we'll be using, this AI-based model, has a number of different really algorithms within it that are based on different kinds of AI tools and also different approaches to deal with the personal identifiable information based on dictionaries, as Mahmoud has described, on also vocabulary, and looking at the surrounding words. And there are different kinds of AI tools with the conditional random fields, as well as the bidirectional long short-term memory models as well, that enable really the ability to try to be highly accurate in terms of identification and then dealing with personal identifiable information. And so the AI models could redact the information, which replaces it with some sort of fixed string. It could replace with a more generic concept. For example, an address could be replaced with a city area, and ages or dates could be shifted. Or in some cases, if the information is not sensitive, so we talked about eponyms, for example, that the identified entity would be kept as is. So these are the decisions that need to be made with the masking algorithm. So finally, why is this project important? Why is it, what significance does it have? Well, first of all, as we deal with an increasing volume of free text information, we need to look at ways to ensure the security, privacy of that information, while looking at how to reduce the potential that sensitive information might be available within record level data. The fact that we're working in a multi-site environment and with diverse kinds of data should help in terms of the generalizability and across a variety of settings, the ability to mask that personal identifiable information. Using the mask algorithm should allow for refinements and updates as new data becomes available for participating sites. And you heard Mahmoud talk about the potential kinds of data that might be part of the masking process in Ontario, and I'm sure the same exists across other sites. And so we can have a system that's up to date and that evolves. Also, as there may be changes in privacy legislation or the challenges that come with masking these types of data. The benefits so far and what we anticipate is that there will be trust in the process by doing this multi-site project and very heterogeneous kinds of data. That we will build capacity within the pilot sites in conducting harmonized analysis. We've been working extensively on building a common protocol, and the collaboration really has been wonderful to help advance our understanding of the challenges across sites and the commonalities. And we will work on this as a pilot, looking to extend it to other sites as well. And that will enable the building of new skills in a variety of areas, including in federated learning, which is a priority within HDR in Canada.